Hi, everyone. My name is Muthiah Vaduganathan. I'm a cardiologist at Brigham and Women's Hospital and Harvard Medical School. And together with a team of cardiologists, pharmacists, and clinical trialists, we reviewed the latest literature regarding the safety of renin-angiotensin system inhibitors in the COVID-19 pandemic. The primary issues revolve around the interesting interaction between the renin-angiotensin system and COVID-19. The virus responsible for the COVID-19 pandemic, SARS-CoV-2, binds the ACE2 receptor in order to actually facilitate viral entry and ultimately further pathogenesis related to the virus. So this special report was published in the New England Journal of Medicine and really summarizes the latest related to the biology, the epidemiology, and current recommendations surrounding the use of renin-angiotensin system inhibitors and COVID-19. I think the principal kind of take-home messages are that there have been preclinical models that have suggested that these classes of medications, the ACE inhibitors and ARBs in particular, may increase the expression of the ACE2 receptor in patients taking these therapies. And really, this has been restricted to animal models and perhaps cell models, and it hasn't been consistently observed in patients taking these medications. So while it has been a theoretical concern that increased expression may lead to increased susceptibility to the SARS-CoV-2 virus, I think that we really need better quality data related to how these therapies influence the expression of ACE2 and ultimately COVID-19 outcomes in patients. One of the main things we wanted to emphasize with this review was that, despite those theoretical concerns related to the interaction of these therapies and the receptor for this virus, the withdrawal of these medications in high-risk patients may actually be particularly harmful in certain cases. And in certain conditions like heart failure and after a heart attack, these therapies are evidence-based, and we know from large randomized clinical trials that their withdrawal may lead to further disease deterioration and perhaps flares or recurrence of the disease process. And so in general, we're recommending currently, until we have further evidence, that we should continue these therapies in otherwise stable patients at risk for or with COVID-19. Since the publication of our report, there have been several epidemiological reports from China as well as Italy that have evaluated patient outcomes in people who have been infected with SARS-CoV-2 who were previously treated with ACE inhibitors or ARBs. And these have suggested that these therapies have either been not associated with, or in certain cases, they've been associated with better outcomes compared with patients not being treated with these therapies. And so at present, in terms of human data, there are no major concerns related to these therapies. That said, it's very hard to really inform core decision-making as well as recommendations from observational studies. And so this has been a topic of great interest and tremendous clinical trial interest. And now there have been over 20 randomized clinical trials now underway targeting this axis. And specifically, the bulk of the trials are evaluating whether the new administration of these therapies is safe and effective in COVID-19, or in people who are already treated with these therapies, whether continuing or prematurely stopping or switching these therapies may be effective. And we'll learn much more about the interesting interaction between these therapies and the risk or potentially even the treatment of this condition in the coming months. Many of the drugs we use in clinical practice, including the ACE inhibitors and ARBs, intersect with the renin-angiotensin system. And so there is reasonable interest in understanding the associations between the use of these very common therapies and potential risks or benefits with respect to COVID-19. But before we actually jump into starting them in routine clinical practice, I think we need to generate the necessary evidence to substantiate these claims and substantiate these recommendations. And until we have well-informed clinical trials to evaluate these therapies in controlled settings, I think that we should maintain the status quo and maintain what we know about these therapies. And what we've learned from really decades of investigation is that these therapies are very important for patients, especially with cardiovascular diseases, to stabilize disease processes. And prematurely stopping them in light of really theoretical concerns around their use may be harmful in select settings. And we know from a lot of the epidemiological reports that the patients with cardiovascular disease really face the highest risks with COVID-19. And so maintaining cardiovascular health during this pandemic is of utmost importance.